Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Risk Factors for Gastrointestinal Adverse Events in a Phase 3 randomized trial of bevacizumab in first-line therapy of advanced ovarian cancer, a gynecologic oncology group study by Robert A. Berger et al. My name is Maury Markman, and I am Senior Vice President for Clinical Affairs at Cancer Treatment Centers of America and Clinical Professor of Medicine at Drexel University College of Medicine, Philadelphia, Pennsylvania. My oncologic specialty is medical oncology. The anti-angiogenic agent bevacizumab has been demonstrated to be a useful component of a number of anti-neoplastic strategies. In ovarian cancer, several Phase 3 trials have demonstrated the delivery of bevacizumab results in a statistically significant improvement in progression-free survival. These studies have involved patients managed in the primary setting, recurrent, potentially platinum-sensitive disease, and platinum-resistant disease when administered in combination with standard cytotoxic chemotherapy. While the side effect profile for bevacizumab administration observed in these trials was similar to that noted in previously published series with this agent, several reports noted the development of bowel perforations in ovarian cancer patients receiving this drug. It is important to recognize that while bowel obstruction is a relatively common complication of progressive ovarian cancer, bowel perforations are a relatively rare event in the natural history of this malignancy. Therefore, the report in one Phase 2 study by Canestra and colleagues examining single-agent bevacizumab in platinum-resistant ovarian cancer of an 11% incidence of bowel perforations raised concern for the potential risk of this highly problematic complication of this agent. It has been hypothesized that extensive involvement of tumor with bowel in association with a clinically relevant delay in wound healing could be the major factors in the development of this negative clinical outcome. In the Canestra study, there was a suggestion that the number of prior regimens, as well as radiographic evidence of bowel involvement by tumor, might predispose to the development of this complication. As a result of this experience, clinicians in research groups dealing with ovarian cancer have taken a number of steps to hopefully minimize the risk of bevacizumab-induced bowel perforations, including delaying the delivery of the anti-angiogenic agent for at least a month following any major abdominal surgery, and avoiding its use in patients with extensive intra-abdominal cancer at evidence of bowel involvement, such as the finding of air fluid levels or a thickened bowel on radiographic imaging studies. In a recent analysis from Berger et al. And the Gynecologic Oncology Group published in the Journal of Clinical Oncology, investigators examined the risk of serious gastrointestinal events, such as gastrointestinal perforations, in the previously reported Phase 3 trial of bevacizumab added to combination carboplatin paclitaxel as primary chemotherapy of advanced ovarian cancer. This evaluation of a large, prospective, randomized study provides critically important data for all physicians and their patients with epithelial ovarian cancer, where consideration is being given for use of bevacizumab in the primary treatment setting. The major points from this analysis involving more than 1,900 patients are as follows. The baseline incidence of serious gastrointestinal events in the absence of the administration of bevacizumab in this large trial was 1.7%, or to simplify the conclusion, less than 2%. Second, the overall incidence of serious gastrointestinal events when bevacizumab is added to the combination chemotherapy was 3.4%, or approximately double the recorded baseline risk. It is relevant to note this overall risk was less than 4%, meaning less than 1 of every 25 patients with advanced ovarian cancer receiving the anti-angiogenic agent in this specific clinical setting. However, it is absolutely critical to acknowledge that in this trial, the bevacizumab was started on cycle 2 of chemotherapy, or in the majority of patients at least 1 month following primary surgical cytoreduction. It is not possible to know, based on these data, the risk of serious gastrointestinal events if the anti-angiogenic agent had been initiated with the first chemotherapy cycle. Third, patients who received single-agent bevacizumab maintenance therapy following the completion of the cytotoxic chemotherapy program did not have an overall risk of serious gastrointestinal toxicity compared to patients in this randomized trial whose bevacizumab was discontinued upon the completion of the cytotoxic regimen. Finally, this analysis identified 3 clinical features that appeared to increase the risk of serious bevacizumab-associated gastrointestinal toxicity: a history of inflammatory bowel disease, and either small bowel or large bowel resection at the time of the preceding cytoreductive surgery. Importantly, the overall risk of a serious event compared to the baseline risk was only increased approximately 2-fold for patients who had undergone either small bowel or large bowel resections. However, the risk of bowel perforations rather strikingly increased 13-fold for individuals with a history of inflammatory bowel disease. Based on these data, it would be reasonable to conclude that following appropriate informed consent, that is, providing patients who have undergone either a small or large bowel resection with information they have a modest increased risk for the development of this complication of therapy, it is reasonable to consider use of bevacizumab in this specific clinical setting, again, assuming patient agreement. This conclusion does not address whether the upfront use of bevacizumab outweighs the cost and clinical benefits of the drug, because although progression-free survival is prolonged, no difference has been demonstrated in either quality of life or in overall survival in this setting. However, based on the data in this analysis, a very strong argument can be advanced that the use of bevacizumab in combination with cytotoxic chemotherapy following primary surgery in ovarian cancer is contraindicated in individuals with a prior history of inflammatory bowel disease and should not be employed in this clinical setting. In conclusion, this important analysis provides highly clinically relevant data that can inform clinical practice in the management of advanced ovarian cancer. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.